Speaker is Dr. Silamban. He demonstrated a beautiful cervical epidural this morning. He will be speaking on higher epidurals for neck and shoulder surgeries.
Good morning, good afternoon to all of you. Let us see about higher epidurals. Let us see how useful they are going to be for us in clinical practice and how difficult is it going to be when it's going to be a higher epidural. As with the usual things, anything we do, we'll have to have basic concentrations of the anatomical space. The contents in the higher epidurals are similar to that of the lower epidurals, but certain things are certainly different. You should understand that the regional epidural space width is not uniform throughout. In the cervical region, it is 1 to 1.5 mm only, whereas in the lumbar region it is 5 to 6 mm. So this is a disadvantage at this level, as the chances of dural puncture are a bit high. But the other advantage is that the cervical dura is much thicker than the lumbar dura. It is 1.52 mm, whereas the lumbar dura is only 0.6 to 0.33 mm. So this prevents accidental dural puncture with help of catheters. Coming to the vertebral spine anatomy, as you can see, these are 90 degrees. The cervical is also 90 degrees, whereas the lower thoracic and upper thoracic are more cramped and at 70 and 60 degrees. So this helps, this 90 degree angulation of spine also makes the administration of cervical epidural comparatively easier when compared to upper thoracic and lower thoracic epidurals. Next is the ligamentum flavum. This is something we must always keep in mind. It is thinner in the cervical region compared to the lumbar region where it is thicker. And it is also deficient in 15 to 20% of individuals. So the classical feel of the needle entering the flavum, which we get in the other areas, may not be felt when you are performing a cervical epidural. Most of the surgeries in the neck, upper limb and occipital region, and as a mode of pain relief, it can be used. Even breast surgeries and cardiothoracic procedures can be done, provided we try to reverse the catheter and thread it caudally. Contraindications, the same as for any other epidurals. Coming to the technique of that, the position of the patient, like I demonstrated in the theatre, forehead on the table, flex neck as much as possible. Other positions, lateral and prone, can also be attempted. Palpation of vertebral spines, the first most prominent spine is C7, that is palpated. Next is T1. So that is the space with which we are going to enter. 25G needle, 2% xylacune or adrenaline for local infiltration. And next, coming to the site and angle of needle entry, how different is it from the other epidural space? That is for the lumbar, because the angulation is 90 degrees, we go between 90 degrees to the lumbar spines and we go straight through. Lower thoracic, the angle of entry will have to be at around 60 to 70 degrees. The upper thoracic, as it is very crowded, one of the most difficult sites to administer an epidural, it's around 70 degrees. And cervical, just like the lumbar, is also at 90 degrees angulation. So because we are very much used to lumbar administration of epidurals, this angulation invariably helps us to achieve a good epidural at the higher regions. Identification of the epidural space is either by the hanging prop test of Gutierrez or by loss of resistance technique, which can be used with saline or air. Hanging prop is very useful in the higher regions because higher negativity, almost 97% positivity is achieved. But even otherwise, if you are more comfortable with the saline or air, you can still go ahead with them. This is the demonstration of a hanging prop sucking, which will not be shown properly in the theatre. You can see it now. It is being done in one of the, not in the cervical region, but in one of the higher thoracic regions. You see the water, you saw the water being sucked in there. Very clearly, water is being sucked in there. The entire column of water must be sucked in before you try to thread in the catheter. Saline can be used, but only 2 ml, not more than 2 ml. Air, same way, 2 ml. Now, before you embark on any epidural and how to go about with the procedure, you must try to achieve a segmental epidural, which is especially very, very useful when you go higher up, because you have the phrenic nerve, you have the intercostal muscles to handle. So, as far as the epidural is going to be segmental and limited to a surgical site, the end result is also going to be better. See, first we decide what are the upper and lower halves of the levels of the area we are going to block. Then we decide where we are going to place the tip of the catheter. Then we decide the length of the catheter we are going to push into this space. Finally, the site of needle entry is decided, and finally the volume of drug we are going to administer is decided. First, we'll have to decide on the dermatomes to be blocked. For example, you are planning a thyroid surgery under cervical epidural. C2 to T1 gives good relief. Suppose you are planning a brachial plexus surgery, you plan to block the brachial plexus under cervical epidural, a block from C4 to T2 is mandatory. So, basically, I of the opinion that moment the epidural space is opened up, the negativity goes up and the drug spreads equally on both sides of the catheter tip. So based on that notion, I always prefer to place my catheter in the center of the dermatomes to be blocked so that local anesthetics spread equally on both sides of the catheter tip. So the catheter should ideally be within 3 to 5 centimeters from the site of needle entry. So if it is greater than 5 centimeters, there is always a problem on kinking, knotting, doubling of the catheter, entry into the intervertebral foramina, and less than 3 centimeters accidental catheter exit either intraoperatively or postoperatively can occur. The site of needle entry is ideally 1 to 2 vertebral spines away from the intended site of catheter tip placement so that we manage to achieve a distance of 3 to 5 centimeters of the catheter inside the space. Whereas the cervical region is always preferable, even if you are going to introduce the catheter a little more higher, it is always preferable to have C7T1 as a site of needle entry. This would be very ideal when you plan it for a cervical epidural. The volume of drug used, like I said, the volume of the cervical space being smaller, 1.25 ml per segment which you intend to block would be the ideal volume in the cervical region as a rough calculation. In the lower and upper thoracic it can be up to 1.5 ml per segment, in the lumbar region up to 2 ml per segment can be used. Now, talking about these principles, suppose we are planning a thyroidectomy, the block is going to be from C2 to C7 and we plan to place the catheter tip in the center, that is going to be C4, C5 space. And the length of the catheter is planned to be 5 centimeters. Then we enter from C7T1, we set the catheter by 5 centimeters so that we place the catheter tip between C4, C5 and at 1.25 ml per segment, planning to block about 6 segments, 8 ml will be the volume of the drug to be given initially. Suppose a brachial plexus, we block from C4 to T2, taking prefixed and postfixed plexus into consideration. Here the catheter is going to be placed in the center, it is going to be between C6, C7. So needle entry is going to be C7T1. So catheter is going to be threaded by 3 centimeters, fixed between C6, C7, the center point of the brachial plexus anatomy, and volume of the drug about 7 to 7.5 ml, at calculated at about 1.2 ml per segment should be quite ideal. When you use it for breast surgeries, I would always prefer not to push the catheter cephaloid. Always try to reverse the catheter and try to push it caudally, so that the phrenic nerve is spared. In modified radical mastectomies, the block required is from C6 to T6. Deep axillary clearance requires anesthesia up to a level of C6. So C6 to T6 is what is required. And if you are going to enter at C7 T1 space, you threaten the catheter by about 5 centimeters. It invariably comes to between T2 T3. That is the midpoint between C6 and T6. And if you are going to have about 1.5 ml of volume of drug, 10 to 10 ml of volume of drug will anesthetize from C6 to T6. Thereby the intercourse only are blocked. The phrenic may always be spared. C3, 4, 5 may be spared, and that may help in maintaining the respiration better intraoperatively. Reversal of the catheter can also be attempted for cardiothoracic surgeries, where the blockade will have to be from T1 to T8, and the catheter tip will have to be from T4 to T5. There is an error here, T4 to T5, and needle entry C7 T1. But because the catheter tip is being pushed in lower, you can either enter from C7 T1 or T1 T2 and push the catheter accordingly. The drugs used, preferably those which do not produce motor blockade, in concentrations where motor blockade is not produced, 0.25% bupivacaine or 1% xylocaine. A video demonstration of the cervical epidural. C71 space. Position of the patient. Local infiltration. Here we are using a loss of resistance technique to identify the space. The needle is introduced, you can see, parallel to the floor. In case there is difficulty in flexion, a little more of elevation of the needle is allowed. If you get a very good flexion, then if you introduce the needle parallel to the floor, you very easily reach the epidural space. Always keep in mind, you may miss the flavum, it may be thinner, but in this particular patient, the flavum was quite well felt. I invariably use both hands to have a better control on the needle while pushing. This space has been reached. Catheter introduction and fixation. Next is the most controversial concept of sedation, which is used during higher epidurals. Controversial drugs used for sedation in cervical epidural accentuate respiratory depression, which is brought on by the paralysis of your phrenic nerve and your intercostals. My opinion is moderate dose of opioids or benzodiazepines alleviate patient anxiety and postural discomfort. Also keep the patient comfortable during tracheal manipulation. And secondly, what I'd like to stress here once again is, if you are going to be segmental, the one component is blocked, the other component always works. If your phrenic is blocked, your intercostals work. If intercostals are work, your phrenic works. So naturally, sedation can be used, but you'll have to be very guarded. Respiration is not affected here. Reason? One, I said cervical dura is thicker, so diffusion of the local anesthetic across the dura is not there. There's decreased concentration of local anesthetic, so only sensory blockade is obtained. Segmental block spares the intercostal nerves very clearly. Slight reduction in tidal volume and slight increase in PaSO2 have been observed, but it is not clinically significant. Patients are comfortable without much subjective respiratory difficulty. Now, any time you insert a catheter, post-op pain relief becomes a must. Okay. Then you have intermittent and continuous catheters. Suppose you're going for intermittent technique, a volume of about 6 ml every 6 hours is what is essential. Suppose you're going for a continuous technique, you have about 300 ml of volume, you infuse about 5 ml per hour for about 60 hours at 0.0625, there's an error there also, 0.0625% concentration. More than 0.0625% is not advocated in a continuous infusion. And side effects are similar like for other epidurals, and some interesting cases that we can do under, which I have done under epidural LIPOMA scalp. This was done in the prone position, branchial fistula on the neck. Here a high neck mass was removed, a mandibular nerve block was also substituted.
Dr. Silamban,
yes,
I've got great respect for you. You showed excellent cervical epidural technique this morning.
It's over.
Because of the shortage of time, can we...
Yeah, I'm over. I'm through.
Thank you. Thank you very much.
Thank you.